The topic is peripheral arterial disease. There is occlusion of the blood supply to the limbs, and this is due to an atherosclerotic plaque. And most commonly, it's the lower extremities that are affected, and depending on how much the obstruction is there, and if there is a collateral blood flow, and if other vessels are involved or not, clinically the disease manifests itself. Usually, peripheral arterial disease refers to atherosclerotic obstruction of arteries to the lower extremities. Well, it depends on how severe this disease is. The symptoms accordingly. And in its earlier forms, the patient would complain of intermittent claudication, and that goes away by rest. But with progression of the disease, the pain persists even at rest, and there is ulceration of the foot, and the blood supply being poor in advanced diseases. The limbs are often very painful and they are cold. Depending on the location of the occlusion, different areas of the limb show symptomatology. If the disease is in iliac, then there is claudication in the buttocks, there is impotence seen in males, and the femoral pulses are decreased, whereas in femoral popliteal disease there is calf claudication, and the pulses below the femoral artery are absent. They're the famous P's that are related to PAD. Those are pulselessness, paralysis, paresthesias, pain, pallor, and cold limbs, which they often call as poikilothermia. They could be an acute ischemic kind of presentation, and it's most often caused by embolization. This kind of presentation, there could be sudden onset of severe pain in the legs, and this could be associated with weakness of the foot, and basically such a patient is a smoker and limited exercise tolerance, and pain in the lower limbs, intermittent claudication to begin with, and these kind of patients basically they have a history, and one could often see lipid depositions in the skin, and often there are lost pulses, and the leg is also cold, and anesthesia is there over the leg. But in cases of acute ischemia, there could be embolization from the heart, or there could be cholesterol embolization. And basically an arterial embolism may have several causes, and coming from atrial fibrillation or myocardial infarction, or with prosthetic heart valves. And there could be a paradoxical embolism from the venous system, and or there could be a dislodged mural thrombus from abdominal aortic aneurysm. And basically, the earlier this is recognized, the chances of saving the limb go up. But most of the patients with PAD experience no symptoms, and this remains an underdiagnosed and undertreated condition. And some patients report intermittent claudication. They say we have aching or cramping in the legs, especially brought around by exertion. And on taking rest, this basically is relieved. But as the disease progresses, like I said, there would be pain at rest, especially at night, and the pulses are also diminished. Often there are bruits that are heard over different locations, like over distal aorta, femoral arteries, or iliac arteries. And the skin temperature is cool, and hair loss is there, muscle atrophy is there. And with advanced diseases, of course, there are ulcers, necrotic tissue, and gangrene. So it's all how much the disease has progressed. So when a patient comes up with this condition, just looking for the pulses and auscultate for any bruits, and basically the ankle and brachial index, also called as ABI, basically helps determine the severity of this disease. And the ABI is calculated, basically they divide the highest ankle systolic pressure by the highest systolic pressure from either arm, and they choose either dorsalis pedis or posterior tibial artery for getting the ankle systolic pressure readings. Then it's divided on the basis of the readings. They try to determine whether the disease is mild, moderate, or severe. And basically, the ABI readings are gathered at rest and during treadmill exercise. And it's basically 1 to 2 miles an hour for 5 minutes, or symptom limited. And if the disease is mild, then the ABI at rest is 0.71 to 0.90. And the ABI during exercise is greater than 0.50. For a moderate disease, the ABI at rest is 0.41 to 0.70. And during exercise, usually greater than 0.20. And for a severe disease, the ABI at rest is less than 0.40. Or during exercise, it's less than 0.20. Rest pain usually occurs with an ABI less than 0.4, and higher ABI can indicate calcification of the arteries. Imaging studies are performed, such as the duplex ultrasound. They help locate precisely the areas that are occluded, and they help assess how much the distal arterial system is basically patent. And rest or exercise pulse volume readings are helpful, as pulse volume recordings measure how's the flow like in different areas of the limb and what is the site of stenosis. MRA can be utilized to have an assessment of aorta and the lower limb arteries. It's a non-invasive way of doing things without using contrast agents. And angiography obviously is the gold standard in this condition and it's basically performed before revascularization. And contrast CD may be utilized, but in cases of renal failures, patients having renal failure, obviously the contrast would be a problem. So in situations where they would not like to use the contrast, like to go with MRA, and angiography remains the gold standard, of course. Diabetes is a condition that leads to PAD, and tobacco consumption, and so if a person has PAD, one needs to be taking care of the diabetes and the other risk factors, heart-related conditions, and keep away from tobacco, and careful hygiene and foot care is so important. Lab-wise, the hemoglobin A1C levels in diabetic patients is important, and hyperlipidemia. In people having hyperlipidemia, it's important to have a lipid profile, and blood glucose monitoring is also very important. Treatment-wise, salt restriction for folks who have hypertension, and for diabetes, it's absolutely important to take care of the glucose and have a tight glycemic control with A1Cs less than 6.5%, and to basically eliminate basically tobacco, like smoke cessation programs are available, and need to walk, exercise training, and improve the exercise capacity. For folks having hypertension, it's important to manage the hypertension and take care of dyslipidemias if they're present, and it basically helps reduce the claudication. Then aspirin, having an aspirin daily for folks having cardiovascular diseases. Clopidogrel provides protection in case of for any cerebrovascular events associated with PAD and cardiovascular and cerebrovascular events. Clopidogrel is very helpful. And then pentoxifylline may help in benefiting the walking distance, and silastazole shown to have patients have shown to have improved walking distances, and but it should not be given to patients with congestive heart failure issues and ejection fraction less than 40, and revascularization is indicated for more advanced diseases, as in people having refractory wrist pains and non-healing ulcers or gangrene, and for stenotic lesions, which are basically short, and they use angioplasty, and in femoral popliteal artery or iliac arteries. But they also utilize surgical revascularization procedures to relieve advanced diseases, and some common surgical procedures being aortoiliofemoral reconstruction, infrainguinal bypass, as in femoral popliteal and femorotibial, and extra anatomic bypasses, as in axillofemoral or femorofemoral bypass. Basically, the arterial bypass or amputation can be utilized when the conservative treatment is not a success, and then it's absolutely important to avoid any beta blockers in peripheral arterial disease, as there could be peripheral vasoconstriction. Differential diagnosis wise, we could consider conditions such as muscle cramps or varicose veins, compartment syndrome, and spinal stenosis, degenerative joint disease of the lumbar spine and hips,